Okay, well, I personally think you presented enough information for this patient that I think treatment is warranted, and we've kind of touched on risk stratification, but when you're seeing a new patient, I throw this out to the group, how are you assessing risk? What's mandatory to be tested in order to decide how to move forward?
So I think the first thing is clinical staging. So we all know that in the United States, we use the right staging system to look if patient has only lymphocytosis without anything else. That's the low-risk group of patients. If they have lymphadenopathies, hepatosplenomegaly, that would be the intermediate risk group of patients. Or for patients who are such as this, who also has cytopenias, anemia, and thrombocytopenia due to bone marrow infiltration, that's a high-risk right stage patients. In Europe, Binet staging is being used in a very similar fashion. So the clinical staging has been established for many years, and it still has important guidance on one of the risk assessment criteria. And then we kind of touched on the other risk assessments as well. I think FISH, so peripheral blood FISH study is a very important FISH prognostic, but also pre-treatment is very important to realize that patients' FISH panel can potentially change from the time of diagnosis. So even if your patient already had a FISH study done at diagnosis, it's usually recommended to repeat that because they could acquire novel genetic changes that might change your treatment decision.
Does anybody have an arbitrary cutoff for how long has to elapse before you need to repeat the test? Let's say the patient was diagnosed 6 months ago and they're treated now. Do you repeat? Do you not? I mean, I don't know that I have an answer to this, but since we're here, I'm curious what your thoughts are.
So you're right, there is no right answer. We've typically used a cutoff of between 2 to 3 years, but that's completely arbitrary. I don't have any data to suggest that things will not change in 6 months or they will change in more than 3 years, but I think that's the general cutoff that we've used. Right. Now that's between diagnosis and first treatment, but between first and subsequent line therapy, we would always repeat a FISH panel for obvious reasons.
Totally agree. What about next-gen sequencing? Is that mandated?
So we do not have a next-generation sequencing test that we do on all our patients because the only one that we actually do would be a TP53 mutation sequencing study because it has implications both for a treatment choice perspective and as well as to counsel patients for how long any treatment response is likely to last. But other mutations may be prognostic, but currently are not quote-unquote actionable, such as Notch1, SF3B1, et cetera. And so we do not routinely get those for all our patients.
But everyone here gets TP53 mutational status.
Now we're starting to, yeah.
Yes.
Mm-hmm. Yeah.
Okay.
And then as we already discussed with this patient, the IGVH mutation status, that is also a very important factor when you're considering treatment.